Bill Gates dropped out of college. Mark Zuckerberg dropped out of college. And I'm dropping out of college. See the similarity? And you're like, yeah, dude. Half the CEOs on the Fortune 500 list dropped out of college. But what percent of people that dropped out of college are on the Fortune 500 list?
How to be patient.
Welcome back to This is now an ASMR podcast.
Ever since we did the coffee Patreon. No, just kidding. Hello.
Welcome
because
back. I can't fix my gain.
They don't know what that is.
It's a microphone setting because we do.
Maybe they know it. I didn't know it. I still don't really know what it is. It's kind of just like something. What is gain? Hi guys, welcome back.
It's here. It's a sound multiplier. That's all you need to know about gain.
Okay.
And it's a company that helps with making detergents, I think.
That's true. Well, welcome back, you guys. Today's episode is going to be an episode I think we've done so far like one a season, which is a grab bag question bank sort of episode where I take questions from the Instagram that we have not yet answered, and maybe we'll answer in more depth next season. But we see if we can talk a little bit about them. We maybe circle the wagons around a topic we've covered before, people keep asking about. We chat.
The questions vary in shape and size. Some of them are, what kind of plants do you have? I don't know if anyone's asked that, but I want you to ask that. And some of them are, how do we fix healthcare in society? And I think we reply very optimistically in our DMs when we say, we would love to make an episode on this, and we probably will in the future. I don't know if we'll succeed in answering that question in a complete and satisfying way, but it's still a great question, one that we have to. So I think we're going to balance out all the different shapes and sizes of the questions today. I actually don't know a lot of them. Margaret's picked them out for today, but I do have a couple
them out.
Circling around the old noggin.
Because why not, First thing, though, how are we doing on our steps challenge? Let's take a check.
Oh,
Let's check
I was
the
actually
scoreboard.
pulling it up right now. Okay.
You're beating me, I think, because I didn't do that well the last 2 days.
So, yeah,
As you guys know, we have a steps challenge on the Pacer app. Okay.
Yeah. If you're not on Pacer,
what is our number one? What's our girl Maggie doing?
I think.
What's her number?
Mags is comfortably in first place with 320,000 steps. She's actually 40,000 steps. Yeah. 22 days left. She is 40,000 steps above second place, who is 2,000 steps above third place. So it's actually really a race for second right now with her way in the lead. She's like the Max Verstappen of
she must
walking.
Have incredibly strong, I can't, my shins are starting to hurt just thinking about it.
That's what I'm interested in.
On the show, talk about our step challenge.
However, rising star, bring your attention down to number 15, Preston, with 172,000 steps, who is just trailing Avi and Elback 91 at the 178, 183 range.
Oh.
And then we have the veteran winner of Weekday Rush, Margaret, in 20th at 161,000 steps.
I've fallen behind.
And we have a grand total of 80 of you guys now. So, loving it. That's it. I think we were expecting 7. So
7, yeah.
We've tenfold increased our expected census on this.
Big dog pack.
Oh my gosh. And somebody messaged me on Instagram. They said, "Thank you for making this step challenge. I'm walking more than I thought I ever would." I'm paraphrasing.
That's awesome.
They actually were okay, here we go. Preston, thank you for setting up the How to Be Pedestrian Challenge. Went for morning speed walks and occasional light jogging, and I thought, why not try doing a 5K? Managed to tackle it, and I did 28 minutes first try. Will update you by the end of the challenge if there are any changes. Thanks. Ends like an email, and I was like,
Thanks.
Keep it up. But
be well.
Yeah, I think this is Alyssa is your name. So Alyssa, great work. You are doing the
Alyssa.
thing. Mm-hmm.
We are proud of you. As your parasocial podcast, siblings, brothers in arms, parents, whatever you want to make us.
We're here and we're proud.
We're stepping. It's a long challenge you've made. It's like, how many is it, 6 weeks?
Mm-hmm. Yeah, I think it's like 5 weeks.
I feel like
so we have 22 days to go.
I got to get back in it. but I feel like I have not been checking it as obsessively as I was the first week. So that's probably healthy for my overall
Yeah. I mean,
mind.
and it's easy to lock in for a week. 5
Yeah.
weeks is, just got to keep doing it day after
That week
day
I got
after day.
100,000 steps out for the weekday rush challenge thing.
That was pretty
My legs
impressive.
hurt for like 4 days after. I was like, do I have a stress fracture right
This
now?
this was her Kilimanjaro,
It was,
and
and now
Everest
it's
is coming
done.
soon.
No, we'll do 30 all of May. It's just 100,000 each week.
I was
May the
thinking
400,000th step be with you. No,
yeah,
four.
that's a good one. I was thinking we could do maybe a unified challenge where as a group, like as an how to be patient cohort, we try to get like 1,000,000 steps or like
Oh, that would be
1.5 million
cool
steps. So everyone's contributing to the total. So that way,
for a
Mags is like our
team.
fearless leader rather than
Yeah.
someone who makes us all look bad. But maybe that's just us protecting our egos a little
I
bit.
love that. I think this is a great thing. As our listeners, our regular listeners know, I think it would be funny if Preston, Dr. Glaucomflecken, who is one of our executive producers, got in a beef. And now I'm wondering if there's just any way to get him competitively involved with the beef.
I
I
think
don't know
I think
how,
Will
but
runs, so we could probably get him to
so do
walk.
you. Yeah. Just something to think on. Here's my first question from the grab bag that is not from the grab bag. And it's more of just a comment. And it's that medicine TikTok has been a mess the last 6 weeks. Like, I feel like there's been more stuff going on and I know that you had Paul Tran on. And so we've been
Mhm.
talking about like content creation and medfluencing. But I feel like with like the way the world is right now, everyone's burnout, the continued burnout in medicine, it's just like, I don't know. I feel like it feels like there's something constantly happening on MedTok. Do you feel that way?
Yeah. It's it just feels like a more tense place,
Mm-hmm.
I guess is how I'd put
Yeah.
it.
Which I feel like usually this time of year, it's like the match. So it's like usually like happy and everyone's like, we're all like, welcome. Or it's not happy. Like, obviously not everyone's happy at the match. But you know what I mean? It's like the
Mhm.
videos that I feel like
There's a
are
lot of,
usually
like,
this time of
super
year.
positive things that come out, and then there's everyone that reveals, like, their my tragic match day story, and then a lot of,
Yeah,
like, commiseration and negative emotions too. I think it's just a high intensity emotion time.
that's true. I think you're right. But um, I don't know. I've just been noticing, I feel like there's like a lot more discourse in med talk than there used to be. Granted, maybe it's just because doing this podcast, I used to never get any of the videos before and now I get them. So maybe it's just that I was like in like creative journal club TikTok before. And now my
Mhm.
TikTok is showing me healthcare videos over and over and then edits from the pit.
And then we react to edits from the pit.
And then we
I
react edits.
I like the pit. I think it's a
Have you
good
watched it?
show. I don't like watching it. I watched the first season.
Oh, you're one of those.
Yeah, and it's nothing to do with the quality of the show. It just
Hmm.
I think when I watch TV, I wanna escape work, and
I feel that.
it's, like, hyper realistic work, especially the psych stuff in there for me.
Uh-huh.
I'm kinda like, you know? And it's funny because I would like to watch, like, Industry or Succession, and
Hmm.
these are, like, high intense corporate cutthroat wars that are
Uh-huh.
happening, and I've tried to watch it with my friends who are in corporate jobs and they're like, I can't watch this is like triggering me, they might as well have Teams messages popping up here, and I'm like, oh, for me it's a break. I'm like doing something else, get at least I'm out of the hospital. And it's funny because those are the friends that like watching the pit.
Really? I feel like there's some sort of like enjoyment of suffering that you don't have to go through in it. Like
Mm.
because I feel somewhat similarly. I will say all of the pit edits got me to watch it and now I'm locked in because I'm like shipping different couples in it. And I'm like, okay, Jack Abbott, Mohan, like what are we doing? Um, but I otherwise agree with you. Like I feel like it is I don't need to be consuming stories about the negative traumas and things that bring people into the hospital and then impact healthcare workers. Like, off the clock. Like, that is not something I need to do. It really has been the edits that got me to lock in. And now I can't look away.
If you make edits, just know you've got Margaret
They're so
by the throat.
powerful.
Yeah,
They're so powerful.
I say that like I don't respond to edits. The problem is the edits that I consume are like it's tractors and like high-powered farm equipment. And I'm kind of like, man, do I want to be a farmer? That thing is, you're telling me that thing is $300,000 and it can like bale several tons like a second of corn. That's sick, you know.
How long have you been being shown edits of farm equipment? Is that
Probably
like
about
an
6
ongoing
months.
theme?
Like before that, no, it used to be like a lot of shark edits, polar bears, dinosaurs. I went through a dinosaur
Why are
phase.
you just like archetype like do you have a 5-year-old boy who has interests? We've got the right thing for you. It's like, I love Sharknado, tractors. Like my nephews, literally you're listing. I'm just like thinking of all the things you're listing are things they also love.
I mean, here's the thing: you could show, I think, any man, 5 to 50, a tractor edit, and then be like, "That's kind of a sick tractor."
But like, I
There's
mean,
something deep inside of a man who just you just like farm equipment and
that's
trains. It's
fair.
cool.
That tracks. Did you know my town it wasn't my high school, but that there was a like ride your tractor to school
Bring your
day?
tractor to school day. Or
Yeah.
drive your tractor to school day. I've been watching those
Yeah.
videos too, where
You're like, I
they'll be
could have
like,
that.
I'm Jedediah, and this is my John Deere F6280, and then all the comments are like, my dad's F6289 is way better than that one, and I'm like, Jedediah, you just got mogged. Good lord! And then
He's got
they're all like tractor
mogged.
mogging each other.
And you're like,
Yeah,
I could
those are
get
solid.
involved with this community. People
I'm
yearn
just
for
watching them outside,
community.
like, man, how does it feel to live my dream?
And you're like, I just after
And then I
the
log back into Epic.
you're like, that's it. Okay. Well, we're gonna take a very quick break and then we're gonna come back and try and question mog you guys with all the questions we continue to
We're gonna
not
answer
answer.
mog your questions
We're gonna answer mog you question
by
mogging.
truth. We're gonna truth max, answer max the question mogs.
We'll be right back. The only person who is more stressed out by our medical training than us is our moms because they hear every single bad test, every question mark around admissions, and every bad night call. And this Mother's Day, I want to celebrate my mom by giving her an anxiety relieving, comforting gift like she gives me. But this time it's going to be from Cozy Earth.
Sometimes we want to say more than thank you, and this time, a great bathrobe and slippers is going to be our way of saying thank you for putting up with us all this time.
One of the great things about Cozy Earth is that everything that they make has a 10-year warranty or 100-night sleep trial. So just like your mom was there through all 100 nights of night shift that you went through, so will your Cozy Earth robe and slippers.
Yeah, and you can get those nights back, unlike the night shift. So let this Mother's Day be a reminder that she deserves care too. Discover a Cozy Earth and how it turns routines into moments of softness and ease. Head to cozyearth.com and use our code PATIENT for an exclusive 20% off. And if you see a post-purchase survey, make sure you let them know that we sent you.
Because home starts with mom. All right, Preston, would you like to so basically what we're going to do is I'm going to go through questions and comments that we've gotten in the last few months
Okay.
on a variety of things. And I'm going to give you a chance to respond. And you can either say, you can go or you can
Smash
say
or pass.
Right, exactly. You can smash that
To
like
the
button.
questions. Swipe left, swipe right on the questions.
Sure, yes. And if you swipe left, I have to answer it. Okay.
Okay,
Ready?
fair enough.
But I'm going to pick ones that I think you...
It's going to be an
that
easy
you
game
would
because I
like.
like to answer questions.
Period. Exactly. Okay. One question that was asked was if we could talk more about harm reduction. And I'll make it more specific. I think harm reduction in terms of substance use, then maybe harm reduction in terms of self-harm or preventing self-harm or things like that.
So like a closed harm reduction or like an open harm reduction, surgical harm reduction. Ortho does a lot of those. I guess when I think about harm reduction, I frame it as this saying. My friend, shout out Daniel, he's an anesthesia resident. He was on the Stanford swim team, and he said their unofficial model is we're not just good, we're good enough. And I think that's how I frame harm reduction, which is what can I do that's good enough right now?
Mhm.
Because I can't
Mhm.
do good or reach the high level of good that I'm hoping to. So I would say there's like a couple categories of harm reduction. One is keeping the patient in care with you, because if you can keep the patient coming back to see you for more appointments, then that's going to give them more opportunity to receive and engage with care. And I guess what I mean by that can be anything from continuing, like on an intake, continuing medications that you wouldn't otherwise continue because you know that they're like very attached to those medicines. It can also be um, pivoting to doing more therapeutic conversation or just listening when you have like standardized templated questions to get through. But I know if I don't make this person feel validated right now,
Mhm.
they're not coming back for a follow up. Or I guess I would never know that, but I have a strong suspicion that this is a delicate person who's liable not to follow up with me. And so the priority is just kind of establishing reporting, and then I can get more information in the next visit. So those would kind of be like forms of harm reduction. I guess what I would say is what harm reduction is not is enabling bad behavior either, or unhealthy behavior. I had a friend. He's my co-resident now, but when we were fourth year med students, we were giving like presentations, as you do at like a noon conference kind of thing. And my presentation was on how the like neuropsychological battery for ADHD testing is essentially just a really close clinician interview. And that's the only one that really has a lot of validity, and all the like little clicky tests that you do on the computer end up just not having great sensitivity or specificity for it. Everyone was kind of bored and they're like, whatever. They're like, yeah, I usually decide ADHD anything. Then Rob comes up after me and he goes, all right, your patient's going to take steroids anyways. So you need to get him on a statin. You need to get him on losartan. Um, we can do aromatase inhibitors to prevent them from getting gynecomastia. Since they're going to take the steroids anyways, you might as well do all these things. And then a resident raised their hand. They're like, at what point are we calling this harm reduction? Or are we just kind of enabling this person's steroid use? And he was like, oh,
Valid.
good point. Because
And at what point
harm
are we
reduction isn't turning
looks-maxing?
yourself into like a men's wellness clinic where we're like, we're going to optimize your like anabolic steroid cycle and make sure that we're prescribing you all of the ancillary medicines to reduce your side effects from this and like enable the gains that you're
Right.
looking for. And I
Right.
think
Like
some
we're
people
gonna
can
actually
frame
blunt.
that as harm reduction when I think that
Yeah.
that's harm enabling, I guess.
Yeah. I mean, I think that there's valid ethical questions that come up, not necessarily with like, I'm sure there is for people in that field, but like when it comes to like harm reduction, I think like there's like a good faith question of like what is the right amount of support and what is enabling when you get into the gray. But I think I agree with you that it can go too far either way. I think often, like based on like a structural approach, like in terms of like what is funded, like where can there be clinics for like harm reduction, or where is there like where is it allowed to have things like safe needle drop off or stuff like that, or um,
Yeah,
other
it's
things
actually
like
it's a huge spectrum. I'm glad you brought up the needle drop off. Sorry, keep going.
yeah.
This is good. You're cooking.
But it's a huge spectrum that I think in good faith it can have different questions, different places. But I think in general, there's been a kind of like people just need to pull their butt, like people need to stop self-harming. They need to stop using substances. They need to stop blah, 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 blah. And then a very much a, like not in my backyard-esque thing of like, I don't want a methadone clinic here, blah, 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 blah. So I think that like when it comes to harm reduction, the kind of impulse can be a bias in a lot of people that I've seen of like against to be like, well, no, whatever. But it can also go too far as to be like, well, if you get the testosterone next door, then we can't help that you're doing that. So we might as well just build a men's wellness clinic right next to it and just happen to profit off of this.
And
Complex,
and
though.
yeah, and actually, I think that maybe I'm being too harsh, and you could make the argument that Rob is Rob, my co-resident, was just arguing for harm reduction, and that the next step would be if you said something like, "Well, you're taking the testosterone anyways, and I don't want you to get it from the dirty street where it could be laced with something, so I'll prescribe it for you. Just let
Mhm.
me manage your testosterone because harm reduction." I think
Right.
I think most people would agree that's like absolutely the line.
What about like, I mean, for yeah, I think it just like who wants the testosterone and for what reason, and who gets to decide what the right amount of impact on testosterone you want, whether that's, you know, body image or in like gender clinics and stuff like that, or whether it's
Yeah.
someone who's like a really old man who now like maybe the medical stuff says hormone therapy is indicated. I don't know. But it's isn't it interesting how it like comes up even in this like teeny tiny like we're going to spend a minute on this question, it brings up this like, well, what about this, and like, oh, I could
Yeah,
imagine
and
this
maybe harm reduction
situation.
could be its own episode, honestly. That's also a good point. So, let's say the patient in Texas actually, you're not allowed, doctors aren't allowed to prescribe medications to adolescents to transition,
Right.
straight up. So, actually, we've gotten into certain jurisdiction battles where the, on-base clinic is technically federal property, so they follow federal law. So if
Hmm.
a child of a service member is hoping to transition and they're seen at a military clinic that's on Texas soil, the military providers can appeal to the federal law to then prescribe
Oh,
gender
interesting.
affirming care. It gets really, really complicated fast. But like,
Yeah.
okay, well, what do you do if you're the military psychiatrist for a patient and their civilian PCP doesn't feel comfortable prescribing the
Hmm.
testosterone or estrogen for the patient? Well, then now is that harm reduction because you're trying to treat, you may be going outside of your scope in a way, but you're also treating a psychiatric disorder or really a whole body disorder.
Yeah, I think yeah, I wouldn't use it as harm reduction then in that point, but your point would be more like the ethical issue of
Yeah,
prescribing it outside of
yeah,
scope.
that's fair. That's fair. It's 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 a different and related principle. And yeah, I did want to clarify that like the testosterone context we were talking about was for a cisgendered man who is looking for cosmetic muscle performance,
Yeah. Yeah.
specifically because there are like medical reasons that we'd prescribe.
It's
Testosterone is not all
interesting
harm
how
reduction.
even just like this conversation about it, like I don't know. The whole I mean, we've been trying. We have been trying to do this isn't harm reduction, but we've been trying to do a like kind of like men's eating disorders slash like men's body image, men's wellness stuff. I think wasn't this friend you're mentioning, wasn't he the one we were gonna try to have on, and then we kept struggling? And then I have a friend,
Yeah,
Jason, is gonna come on. Jason is in the step challenge and he texts me and I
Jason.
go, I can feel the creatine pumping through my veins right now. So I was like, when are you coming on the podcast? And he and I would talk about lifting after like clinic every day. And I would just be like, Jason, he's also child psychiatry, shout out. Um, but yeah, harm reduction would be a good episode. It seems like we would have a lot to talk about. And the
Mhm.
ethical nuances of it are very interesting.
Okay, I know you have more questions to get to, but last point. Did
Yes.
you see there's like a fentanyl, I think it's a fentanyl clinic in either Portland or Seattle? The
Oh,
New York
really?
Times did an interesting pod on this 1 or 2 years ago, and it's essentially the next step beyond a needle exchange where they also supply clean opiates that like
Hmm.
non-methadone clean opiates to patients to use. And
Yeah.
it's like a safe place for them to use and a place for them to have safe needles. And so it's doing okay in the Pacific Northwest, but I think that's also like an interesting point or data point along the spectrum
Yeah.
of like harm reduction versus enabling.
Yeah. Because my
And I
gut
can see
instinct to
arguments
that is
for and
like,
against it.
no.
That's
And
that's
like,
too
it's
far for
interesting that
you.
now,
Yeah.
yeah, which is kind of just arbitrary. If I think about it, like it is kind of it's both arbitrary and a bias, and also we know from like the opioid crisis that like when we gave more access to opioids, if opioids are an abusogenic substance, like they are more likely to make a normal human brain become dependent and seek more and craving and all those things,
But
then
this clinic
having
is
more
for people who are
access.
already dependent, so then it adds
Exactly.
another layer to it.
I
Yeah.
love how we're going to give you guys answers as a joke. This episode, and now we're like, what if you give us a question and we give you 40 more
Mhm.
to tinker with?
Yeah, so really, you wanna speak more about harm reduction, we'll highlight the harm reduction and enabling live on a continuum with each other, and it just depends on where you want to draw the line,
Yeah. And who you
and
are
we're
and
trying to figure
how
that out too. Yeah.
healthcare and the law will see you. Okay, cool.
Mhm.
Great work. Okay. Someone said, they said just autism. That was all they said. We can do an episode on autism.
Mm.
I need to think about
I'm
people we
gonna
could ask to.
I'm gonna pass on autism. It's a hard question.
Hard.
Is it just autism period or is it autism question mark? Because those are two different.
Actually no. Oh, you can't see that. There's no punctuation.
No, no punctuation.
It's just autism, like on its own.
Mm.
So we will do an autism episode. I should ask more questions because like there's so much we can cover there. Someone said,
Oh, I think this is a common one that people have asked us about too, which is like
mm,
detecting autism in young boys versus young girls.
hmm,
So
yeah,
I don't know if you have any expertise or like experience on that yet in child fellowship, but
I
that could
definitely don't
be.
have expertise yet. I will say I will not pass on this one. I will smash this question. I think that there are ways in which young girls are socialized, and there's always there does appear to be something different between biologic girls and biologic boys in terms of development. Where people then take that in current kind of discussions in public about like why are boys falling, this is like generally true for like why are boys falling behind in school, what's a 5-year-old boy on average like in terms of like verbal and emotion regulation versus girls, da 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 da. That's outside of autism. And then there's a socialization upon the biologic kind of base, which is equally as strong, if not stronger, in some ways, in my mind. And I think the combination of the biologic differences in girls versus boys within autism and then the socialization combined to just make the presentations look different. I also think socialization for girls with mental health illnesses is a hell of a factor in terms of like internalizing versus externalizing behaviors. So girls tend
Hmm.
to internalize more, boys tend to externalize. That is generally true. And I think in autism, there's a way it does show up more similar to like the ADHD literature that may be less clearly disruptive.
Where
But with
like
autism, it also
inattentive
depends.
subtypes are more common in
Yeah.
women and
But it
the
depends on what
hyperactive.
level we're talking about of autism too. Like, are we talking
Mhm.
about like kind of level 1 autism, which is like quote unquote high functioning and like these like people who weren't diagnosed super young versus like going to like the level of autism that is like when there's like not
Can we
ability
roll
to
through the
speak
levels really
nonverbal.
quick?
I
Level
no,
1, 2, and
we can
3?
do it. We can
No?
do a full
Okay.
episode on this, yeah. Because I don't know enough detail on that to
Okay,
speak on
okay.
that yet of like levels. But like yes, we could. And in fact, there's someone who I've been meaning to email who like did a really great autism lecture for us that I think could be great to come on and be an actual expert because I for sure am not, and I would I would love
Okay.
to keep learning from him. But to the point about girl versus boy autism, like any illness can look individual for any individual regardless of gender, but I do think the socializing and then probably something about the neurobiology is
Mhm.
responsible for different ways that it comes out in the genders that may or may not make it harder to recognize
Yeah,
or diagnose.
absolutely. The other fascinating thing, about autism in that I've observed is its relationship with borderline personality disorder. Not that they actually directly lead to each other, but I've had patients with borderline personality disorder wonder if they may have autism, and patients with autism wonder if they may have borderline personality disorder because both disorders have difficulty with affect regulation, recognizing other people's perspectives, maybe, hypersensitivity to either a certain emotional or physical stimuli. So it's kind of easy to confuse both of those. I think it was fascinating when I was doing mostly my adult clinic. I had several patients with borderline personality disorder saying like, I think this might all be autism. And I thought it was kind of like a one-way street. And then when I was started doing CAP psychiatry this year, because like I'm not doing CAP fellowship, but like we all rotate through it. So I've been in a CAP clinic this whole year. I've had several patients with autism that are like, actually, I think the psychologists were wrong. I think this is borderline. And I was like, whoa, like to tell me more about that. And it's the same reason. This is the emotional dysregulation, trouble recognizing these things. And then they almost want to be shed of that label of autism. So I just kind of found that to be like an interesting dynamic between the two diagnoses.
Yeah. Yeah. No, that's fascinating. I've not really like thought about that. And it's also interesting to think about like, if we think about Marsha Linehan, who is alive, if we think about
I
her
don't think she's
understanding,
autistic.
well, neither do I. uh,
We're not commenting on public figures' level of autism.
this is gonna
We're
ruin the
presuming
tour.
those things.
um, her understanding and kind of of like how does BPD happen is from like a combination of an invalidating environment and a level of a kind of high affect or difficulty with emotion regulation child. So it could be like a child that doesn't have any kind of genetic loading and then like a really, really difficult or traumatizing environment to an extent, all the way to a kid with a lot of difficulty or like you think of this is not true for like all colicky babies, but you think of like the babies that parents are like, we just have been really struggling really hard this whole time. And like, they just seem angry, like a more irritable child, and you put them in an environment. So if you think about like a sensitivity within autism, um, like the ability or the capacity for the family to respond to that and hold that well, like it kind of fits with Linehan's understanding of BPD. Not that that always happens or that it's like causative, but it's interesting to think about of like a child with different needs. Can their environment be validating enough for them to feel attached and connected and consistently?
Yeah, it's not to oversimplify it, but it just becomes nature and nurture.
It does. Yeah.
Yeah,
But then
like
you come in and you're
everything.
like, okay, well, which part should we fix? You're like,
Nature, nurture, and then I just spam it. I just say nature, nurture over and over again, and
I
hope they get
say
better.
medication, therapy, lifestyle change,
Mm-hmm.
medication. um,
Don't you
yeah.
wish you could just shout lifestyle change at people and then they get better?
What do you think my clinic is?
Yeah, it's actually my private practice. I just yell
I
lifestyle
just, yeah,
changes, and
I just say we
if I
need to
don't
go on
yell
a
it loud
walk.
enough, then probably just need to turn up the volume next time.
Although that is like one of the fun things of child is like, I feel like now going back and like treating adults, like part of me just wants to be like, maybe are you having a hard time opening up because it's like where there's resistance or there's whatever, blah, blah, blah. I'm like, well, would it be better if we just like walked and got and talked and did our session while we walked and got coffee or got ice cream or like went on a walk along like the Charles River? Like, would your session just be more productive because you're just someone who like processes things better moving? And I feel like with kids, you have a lot of creativity of being able to do that. And I don't know how this is related to it, but I just feel like I wish I could do that more with adults.
I mean, you could open up a hiking therapy clinic. Sure, I think some people do that already. What are your thoughts on oppositional defiant disorder? And I guess this is a hot take from someone who's not a child psychiatrist, but I have met several patients that carry the diagnosis of oppositional defiant disorder, and after quite literally treating them like an equal or doing some like normal empathetic listening, they are not oppositional or defiant and actually somewhat like
Mhm.
engaged in like treatment with me, which to me seems inconsistent with the diagnosis. So I've wondered, maybe incorrectly, possibly incorrectly, in the back of my mind, is it possible that this is just the externalization of parents and caregivers that don't know how to relate to this kid? And that's why we're giving them
Yes,
that label.
100%. Yes.
Okay.
Do I think that's why it happens most time? Not necessarily. Have you ever considered you're also just such a good doctor that they walk into your office and you cure them immediately?
It is possible. I did shout lifestyle modifications at them on their way in, and I'm not taking that into account.
Yeah, like I did jauntily kick a soccer ball around and made them feel at ease with it.
And I have one of those mugs that say "World's Best Doctor." So there's a lot of really strong factors
A
pulling.
lot. It's it's correlation, not causation.
Yeah, what if actually the second they sit down in my chair, I cure them of their oppositional defiant disorder? So it's really it is a real disorder and exists. It's just I am the cure for it.
Right. You're like Jesus in a
This
way.
is
And I've always said that.
kinda yeah. I'm glad you're finally saying things online that you believe and say offline.
Right. I mean, I have a
The
burner account for those things. I make the edits of Preston.
the, the gospel himself. Yeah. Okay. It's just validating for you to hear that too, and maybe like it's just for like thrown around as a diagnosis, but in some cases it does apply.
Well, ODD is highly comorbid with ADHD, right? And so that presents the question of like, how is the ADHD needs being kind of behaviorally conditioned? And so
Mm-hmm.
I think ODD is a valid diagnosis, but I think it's complicated by how comorbid it is with ADHD, and like actually handling ADHD well in like an informed way is difficult. And then also kids do grow out of the ODD diagnosis. Like as in like the symptoms tend to over the course of a lifetime reduce. Whether that's like the same story as ADHD where we were like, they go down and now we're like, we think they go down, but maybe also we just don't know how to look at it for adults is a whole
Maybe
question
we just
otherwise.
started judging them for it.
Maybe
It
we
didn't
just said,
go
shut
down.
up.
We just started calling them failures.
Maybe we just said, knock it off. So, but I do think it goes down over time. So I don't know if there's something about maturity and like whatever. They said, cut it out.
Yeah, I'm just picturing like you have ADHD and you have all the same symptoms and none of the behavior changes, but at 18 we're just like it's not ADHD anymore. You actually
It's
just
looking
suck.
good.
Yeah.
It's looking good.
Yeah, ADHD symptoms don't follow into adulthood. It just turns out they're shitty adults.
Can I tell you one of my like pet peeves that's going to sound like the opposite of this though? And it's like online where like people will be like, did you know? And it like the neuroscience of like they're going so far.
When they say neuroscience says,
Yeah.
who's neuroscience and why is he saying this? Or she's saying
Yeah,
this?
she's got a lot to say. But like I feel like it is so common with ADHD where it'll be like and I think that there's like a big way, you guys know this, listeners, you know this, like women are undiagnosed, people are undiagnosed in general, people don't get the help they need, there's systemic issues, da 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 da. And at the same time, it just grinds my gears when it's like to try to like people feel unheard and then to address that, we just give them misinformation. And I don't even think people know that they're necessarily giving it misinformation, but they like find like a recap of a study on like a random website and they're like, I just feel like there's 800 things I'll see online. They're like, did you know ADHD brains actually like can't think about the color purple because purple's a long word and ADHD brains can't think about that long enough. And it just like pisses me off because it's like, you are not helping this misinformation. Like,
Yeah. Or I think one of my favorite ones, this is like not necessarily related to ADHD, but they did a study on like high IQ people or something. Like they had them take the Mensa IQ test and then they found that they like report that they procrastinate at a higher rate than the general population. And then they come out there and you're like, it turns out that if you procrastinate, it may be a sign that you're more intelligent. And you're like, first of all, and then all these people that procrastinate are like, I knew it, I was a genius.
knew it. And it's like, it's one thing when we're like, this is a Facebook mom post. Like, this is a post that we know we're being a little silly, we're being a little haha. But some of the people in those comments and the people making them are like really serious.
Well, and they say neuroscience says that if you procrastinate, it's a sign that you're more intelligent. And it's like giving the same energy as saying,
first of all, you should have gotten over that at 18 when you got over your ADHD. So
right,
false.
yeah. Like Bill Gates dropped out of college. Mark Zuckerberg dropped out of college. And I'm dropping out of college. See the similarity? And you're like, yeah, dude. Half the CEOs on like the Fortune 500 list dropped out of college, but what percent of people that dropped out of college are on the Fortune 500 list? Like, you got to look at
Neuroscience is
it the
silenced.
realistic way. Yeah. Yeah. Gagged. I clocked their tea, really.
Clocked their tea. I don't know. I know you and I talk about that offline after I tell you you're the second coming of Jesus Christ, et cetera, et cetera.
It's a nighttime ritual at this point.
But it's just like, I see them every day, or someone will be like, do you know what? Okay, this is me being a hater. I feel like I see a lot of videos, and maybe I am just being a hater, but I'll be like, I'm a neuroscientist, and I look at their credentials and I see no credentials that are like, I'm a neuroscientist. I'm like, just because you took a neuroscience class, I don't even say I'm a neuroscientist. Because I'm not a PhD in there. I'm sorry, I'm being a hater, but then they misquote a study, and that's why it really pisses me off, because it's like, if you
It's a
were
1-2
quoting
punch.
the research correctly, I wouldn't really have that much of an issue with it. But it's both together that I'm like, can we stop? Make neuroscience uncool again.
Stolen valor. Yeah.
Stolen valor. Okay, let's move on to the next question.
We have questions. Yeah.
We don't have answers, but we do have questions. Oh, I have a question I can ask you for that. Okay, so question for you is, now that you're like getting to the end of third year, how do you plan to like spend fourth year? Like, do you get like elective time, or do you have any things you're trying to do before fellowship?
So actually, I'm on a research track. So
Boom.
my fourth year is kind of the same as my third year.
Okay.
So I'm like continuing in outpatient clinics, but I have like more time per week to dedicate to research. And I think what
nice.
I'm planning on doing is possibly doing like certain like electives where maybe a couple days a week I'll be like helping out on the inpatient consult service, or
Cool.
like going in and like helping. Like we have a thing called Back to Bedside, which is actually where we go take the interns in the hospital to like certain patients and like show them therapy techniques in the hospital, like little like
Oh, that's super cool.
PRN supportive psychotherapy stuff, and we do like mini lectures. So that'll probably be a big part of it, because I am interested in therapy. And if you're an incoming intern, you're gonna be getting a lot of existential psychotherapy. Sorry guys, but that's what
Here
we'll be
we
talking
go.
about. And
Someone
then
told
I
me
guess
that they really liked. Oh, I talked with someone in real life for an interview thing, and they were like, I loved that you guys did existential psychotherapy as part of it. I didn't even know psychiatrists thought about that. And I was like, we be thinking about it. So
like,
I was
we
like,
do.
Preston was reading, and then we were both thinking.
You're like, Preston got excited. He just learned how to read, and then he found all these books, and he's just been digesting them.
I said he's hooked on phonics, and he has. We have a little star chart and everything.
I've yet to be unhooked. Yeah, so fourth year I think will be good. For my research, I've been doing a lot of like MRI imaging stuff, looking at like kind of describing possible new radio imaging biomarkers for Lewy body.
Mm-hmm.
And then that's kind of what I'm doing with my PI. Personally, I kind of want to get into looking at communication. So a lot of people have been using AI to write their notes, but with that, a lot of those programs actually save verbatim transcripts of the conversation. And then what I kind of want to do is take that and run it through the like motivational interviewing templates, or maybe even create a new template and examine the therapeutic utterances that are given in different patient encounters.
Oh, that's cool.
My hypothesis is, if you are engaging with someone of a similar age, ethnicity, or gender, you're more likely to use affirmations, validating utterances, complex reflections, and have more open-ended questions. And I think people, maybe with the different demographics, might use more close-ended questions, for example, or actually spend more of the session talking. So I think the metrics I'd look at were like percent of the session you spend talking, and then like the amounts of the different utterances. And I think that just be kind of interesting.
Guy now?
I mean, I find it. Yeah, I've always
you
kind of
like
found it
Krabby
fascinating.
Patties, Squidward.
Yeah, I do. They're so
That's
good.
cool though.
Yeah, and I think like the data is already building itself, so we might as well look at it. And it's nice because it's already anonymized.
Mm-hmm. Yeah.
We could just scrub them. They're rote transcripts, and then all you need is the demographics of whoever the therapist is, and whoever the patient is.
That's true. Yeah, that would be cool. That would be cool. It'll be interesting to see like how that plays out. I think even just like the methodology would be interesting of like how you're
Mhm.
getting the data.
Yeah.
Cool.
And what if it's not like that'd be interesting too, Turns out, gender doesn't play a role, but like race does in,
Yeah.
differences in therapeutic utterances. Like that could be really fascinating also.
Well, and also the like, I don't know, in the setting that you're in, like, does that apply? Does that generalize outside of like, is it the same everywhere? Is it the same as a clinic in Boston, the same as a clinic back in like Southern Illinois for me? Like,
Mhm.
probably not. It would be my hypothesis, but we can't know until we look at the data. I wanted to circle back to the question we started with because I meant to say something about harm reduction, which is uh gonna feel out of left field, but I need to say it because I feel like the person who asked may want, I don't know if they'll want that, but just like concrete things that I feel like I found to be really helpful for people. If they are if this is like literally so the harm reduction substance, I would think we covered that. But harm reduction like self-harm, in my mind, when someone's like, I struggle with like cutting or scratching or something like that, I ask them more, or with like skin picking excoriation, I ask them how much of it is like unconscious when they start. So, like a body focused, repetitive behavior. And then, because I find a lot of my patients will cut, but a lot of them will also have like, their like nails are picked down and they pull at their skin and they pull in their scabs and they like pick their skin on their face. And like, the thing that maybe my hypothesis is that like makes self-harm a way of regulating is also something that makes any type of like pain stimuli. I think people have done this research, but like pain stimuli more soothing to them. And if that is getting in the way, like if they're like, my nails are always bitten down and like painful in a bad way, my skin is whatever, or like I feel like cutting whenever I can like feel whatever. Um, One of the things to do is to create barriers similar to how you might with substance to make self-harm more difficult to do. And so if they have the like scratching kind of like they start scratching and pulling at their skin and they don't mean to start, they just do it when they're like searching for a skin tag or something, having um have if it's more body focused, like repetitive behaviors, having like nails for a lot of people can be helpful, like as in like acrylic nails, because there's less
Mm,
sensory input and therefore less skin picking, which can lead to the cutting and lead to like more pain seeking. So having like fake nails can be extremely helpful for them. If there's
that's so
someone who
interesting.
picks, yeah, if there's someone who like picks at their face or like pulls their hair, which, can be a compulsion, but I think I'm sure you've seen this. It can kind of toe the
Yeah.
line between like compulsion and self-harm and um
So like a wig,
one of those then.
would that help?
So, I mean, actually like a wig might help. I was going to say for trichotillomania maybe less so, but the nails will still help because it'll reduce the sensory input for people. But I was going to say if they do the thing where they like go in the mirror and are like looking at themselves and then they start like scratching or hitting themselves like in the bathroom, turning the lights lower and having like less good mirrors, not because they're like it's bad to look at yourself, but just like reducing the thing that starts the self-harm, like reducing the
Mm,
intensity of some of these things. And I just find a lot of people who like cut with a razor also have these other kind of skin picking and body focus stuff. So I just wanted to get that out there. Sorry to bring it back, kind of
no,
unrelated, but
it's good. I think any chance I have to hate on overhead lights is a good chance to do
no.
something good for the world, because it really does come down to overhead lights being the greatest evil.
The cause of psychiatric illness when you think about
Really,
it. Just
yeah,
kidding.
it's you just so when someone comes in my office, I scream lifestyle changes at them. I say, "We're gonna get you some acrylic nails, and there better not be any overhead lights in your
You
house."
say we're gonna
Another
glow
hard
up
day's
this shit.
work. So
Like,
what's
first of
looking
all,
too
your
good?
nails look awful.
And you are no longer oppositional defiant. I'm changing your diagnosis.
I've changed it. I changed your look and I changed your
You're
diagnosis.
Meanwhile, like the 14-year-old boy sitting across from me with the acrylic nails is like, help.
He's like, I don't get how this is supposed to help me.
You can just say you're
Okay.
welcome.
The last question I have was whether we would be, this is like too broad of a question for us to do anything
Okay.
on, but people want to talk about PTSD in veterans. And I think that could be a really good episode for us to do, and to do a history of like PTSD as like a diagnosis and how that led to like funding for a lot of different things for wars. And then also your experience with
Oh, I would
working with your
actually,
population.
that I can do a lot about that. We can do the history of PTSD. We can talk about the comorbidity between PTSD and traumatic brain injury. So you're actually
Oh,
more
yeah.
likely to develop PTSD
Makes
if
sense.
it's during like a concussive blast. That's like related to
Oh,
the initial trauma. And then, and even like anecdotally, like I work at a pretty high volume VA, and we're now at the point where like I guess I've seen veterans from 3 different conflicts. So we have like a couple Vietnam veterans that still come through. We have the Desert Storm veterans, then we have the War on Terror, which they all
mm,
kind of come with different flavors of PTSD based on the type of conflict that they were in. So that could
yeah.
also be like a pretty fascinating episode where, like I guess to give a teaser, like we're in Texas, right? So if you're used to the war on terror, or your traumas came from the war on terror, where you're in like, let's say Afghanistan, and you're on a base where you're doing patrol, and like your greatest concern is that a Toyota Tacoma filled with C4 is going to drive into the gate and explode. Now 20 years later, 10 years later, you're driving through 410 on San Antonio. Do you know how easy it is to find a Toyota Tacoma on the highways in San Antonio? And you're just doing your business, and you look in your view mirror and see a Toyota Tacoma that's like coming up behind you, and you're like trying to keep it together on the fucking like family vacation, and you're like, bro. So it's like fascinating, right? Because
Yeah.
there was also a lot of big differences. So and I imagine like in World War II, I don't know how many things like emulate the beaches of Normandy when you return home, right? Like that kind of battle. But when you're fighting an enemy that's embedded into the population, and then you have to return back to a society that imitates aspects of that same population that you were fighting earlier, it's just so likely to trigger the PTSD. And and it was funny is like for the Vietnam veterans, they're like, I could give a crap about a Toyota Tacoma, but God forbid they go to the botanical gardens with their family,
Hmm.
and, everyone's getting concealed behind the foliage, and they're, playing peekaboo in the monsteras or something. That's gonna like bring a lot back. So
Wow.
like
Well,
that's
yeah,
been
I
kind of
agree.
interesting.
Let's do this episode. I want to learn.
Okay. Yeah. So that's just kind of like a teaser, but super interesting stuff anyways. Yeah, we can get more into it. Uh that's all that's my ad for the PTSD episode when it does come out.
I love it. Watch where you get your podcast. Um,
Mhm.
those are all my questions that I selected. There were many more that we could have done, which we appreciate. I mean, we use your questions when I plan episodes, when I put the question box up. We appreciate also just like obviously people's active engagement with this and helping us know what you want us to talk about. Um, and all the comments and everything else like helps us. And then the Spotify is really just for partying in the comments. That academic mode is off on Spotify, but we are going to take a quick break and then we'll be back.
And we're back from the rando Patreon. Hope it was fun and spunky. It might have just been us playing bananagrams, but who
Why are
knows?
you talking in this way? Why are you talking?
This is just my
like a
voice.
radio?
This is how I talk. I tried doing a Patreon episode with the craziest podcast, and you won't believe the things that came out of it. Oh my God. Now time for the outro. Thanks so much for listening. If you enjoyed the
Please
podcast,
stop. Please stop.
Keep
Okay,
listening.
Go back. I won't complain ever again.
shout out to William. This is coming straight from the Spotify comments. This is for the a comment about last week's episode, Coffee, Tea, and Dementia. Hey guys, I don't know if this is the reason why they didn't include cancer patients, but it's been shown that there's a negative risk of dementia when someone has a history of cancer. So since they're reporting risk in this paper, it's possible that cancer itself would be a confound. Here's the paper, Investigating the Association Between Cancer and Dementia Risk, a longitudinal cohort study by Zhang et al., who I think was one of the authors. I remember it was, I know Wang was the PI on that
First
paper,
author.
but I'm pretty sure I
Yeah,
saw
yeah.
Zhang's name thrown around too.
Yeah.
So this is like it's universe building, I think.
This is why we do Journal
This
Club. This is why I like these Journal Club episodes, because someone like actually, I was like, I have this question, and then they're like commenting and they're like, oh, actually, here's the answer. See, guys, I like to learn from them too, because I know they're going to be able to do sometimes stuff like this in the comments.
Well, thanks, William.
There we go.
You're making our pod better. How's the show? We always want to hear what you think, like we did today. We will talk about your questions, answer them, make up our own questions. If you give us a question, we'll come back with 4 more and probably less answerable, but we'll have fun while we do it. And I think that's all that matters. If you've listened, you won. And maybe you also had fun. Come chat with us and our Human Content Podcast family on Instagram, TikTok at Human Content Pods, or over at our team directly on howtobepatientpod.com. You can find me at It's Presro, Margaret at Bad Art Every Way. Bad Art
Every way.
Day, not every way.
Rebrand.
Her ways are good.
Rebrand.
Also on Instagram and Substack, outside of TikTok. You can find full episodes on my YouTube channel at It's Presro. You can also find us on video on Spotify, and then listen to us anywhere you get your podcasts. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Shout out Jason. You notice that Jason makes this symbol when he inserts himself in? He's like, I'm more of a lifter, so if you do a lifting challenge, I'll do that one. Jason out.
I love Jason's edit so much. I would go and watch the podcast again just to be like, where's Jason? What did he do?
Shout out Jason. Our music is by Omer Ben-Zvi. To learn more about our program disclaimer and ethics policy, submission verification licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a Human Content production.
How to be patient.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.